healthcare has been one of the central issues in the way I got brought into this. Is healthcare has been one of the central areas of labor conflict in California and in the United States for over a decade now, as healthcare premium costs have gone on. Healthcare premium costs have doubled in the last 10 years. Sort of puts in perspective, when you think about saving 30% of healthcare costs, you're talking about slowing growth by 3 years in our current trajectory. It's quite kind of daunting when you look at it in that context. So what I want to talk about is the health reform proposals that are on the table in the national debate right now. They're all hybrid health reform or shared responsibility systems. What that means is they all build on the current system. As Obama said the other night, no one who's currently has coverage will be required to change that coverage under the proposal. So they build on our existing system of job-based coverage that came into effect during and at the end of World War II. And in those models, risk and responsibility are shared by the public, individuals, employers, and healthcare providers. Just to give a picture of sort of why start from this idea of building on our current system. And the basic idea is that people are very afraid of disruption. Currently, of the non-elderly, people below 65, about 62% receive coverage on the job. That's either through their own job or a parent or a spouse's job. Over 16, 17% of the non-elderly are uninsured, and or 17% are uninsured and a little bit lower are on public programs. If we include people on Medicare, so go above 65, you actually have currently about 29% of people in the United States are insured through a public program. So all this debate about public options and do we know if they work, we've actually got the third of the population in some form of a public option right now. So I want to go through the major elements of these reform proposals. Again, the two have broad areas of shared risk and shared responsibility. Under shared risk, there are four main components: insurance market reform, the exchange, public plan option, and affordability. So insurance market reform. The basic point here, and this is where I think you've got the broadest agreement on health reform, is the basic idea of guaranteed issue and community rating. No one being turned away from purchasing health insurance because they have a pre-existing condition, because of their age, because of their gender, or because of their health history. That would be an extremely significant reform, extremely significant changes. They all would allow to have some form of community rating. The various proposals vary in how they do this. In the House bill, H.R. 3200, and in the Senate Health, Education, Labor, and Pension Committee, the variation based on age is 1 to 2. Basically got a 1 to 2 rating, in the meaning the oldest don't pay more than double the youngest. Senate Finance is talking about 1 to 5. Currently, the current world in California is about 1 to 7 in terms of what you pay if you're 60 versus what you pay if you're 18. Advantage here, and whatever you do, you're going to have to phase into it, right, based on existing plans. But where the real affordability problems hit are people who are in that not quite area. Put it all into position, say you go to 1 to 2, it does mean costs for the younger people are going up, right? So there is some balancing there, but if we really want to address affordability, getting to 1 to 2 over time, I think is an important move. The other thing is it doesn't allow for rescissions, meaning you can't drop somebody's health insurance. Beautiful. That looks good. Now let's see. There we go. So that, in terms of the question of rescission, you can't drop somebody's health care because they are sick. There are other sets of insurance market reforms, some things that Will taught me about, which are included in the Senate bill in I think their the best form, which is risk adjustment. Basically saying all the insurance companies are going to have to pay into a pool, and then it's going to be given back to each of the insurance companies based on the risk profile of the people who they insure. Why is that important? Well, the reason that's important is right now, if you're really, really good at AIDS care, or you're really, really good at dealing with diabetes, what's going to happen? People with AIDS or people with diabetes are going to come to take your product. What happens to you then? Your cost goes way up and it makes you uncompetitive. Right now, the way insurance companies generally compete is by cherry picking and lemon dropping, right? It's really hard to do the kinds of things Will talked about, the sort of innovations that make coverage cheaper. I mean, there's all sorts of discussion right now about bundled payments and taking steps and measures to discourage, people don't need 3 MRIs in a week and all of those kinds of things that are going to bring down healthcare costs in terms of changing how you pay for healthcare. That's where we need to go. Well, why aren't insurance companies doing that today? Shouldn't that make them do better in terms of the market? Well, Kaiser is, and they've done some very innovative stuff. But right now, it's just a lot easier to figure out how to get the really healthy people into your pool and how to get the really unhealthy people out of your pool. And if you look at what a company like Anthem WellPoint does, they're brilliant at it. They all, if there was a Nobel Prize for figuring this kind of stuff out, they know how to do it, and it's how they've been as competitive as they are. This is one of these things, again, where you sort of go back to, well, is there any welfare benefit for the economy as a whole from doing that? I think most of us would argue no. That's, brilliant knowledge, not well utilized. But that is, as a for-profit company in the world that we have today, that's how they make money. Then we have all the, Will said half of our health insurance companies are nonprofit, but when the nonprofits are competing against for-profits who are cherry picking and lemon dropping, they've got no choice if they want to have a decent risk pool to follow the same measure. So by sharing risk, by creating these broader pools, by using elements like risk adjustment, we can change the situation so competition is based on price and quality and not based on getting rid of the sick and finding the healthy. Next element that is central to this is the exchange. I know there's been a lot of confusion. I think, as I've watched sort of debates and public reaction, I think a lot of people are confused between, well, what's an exchange and what's a public plan? And those are two different things. The exchange is basically, say, a marketplace. And there are different versions of this, and this is an area of debate that has not received enough attention. The basic idea here is if you don't have coverage through your employer or you're a small business, you can buy coverage through the exchange. The exchange, like a large employer plan, will offer you, or like CalPERS, will offer you a wide range of plans to purchase. The basic concept has been there'll be a very large number of private health insurance plans and one public plan or more within what you can buy in the exchange.